Welcome everyone to our second annual Student-Led Clinic Symposium. We're so glad all of you can make it out here. My name is Elena. I'll be Boardman. I'm one of the fourth year medical students on our executive committee.
I'm JB. I am the Director of Finance of the Rose Park Clinic. We are so thrilled to have everybody here today, both in person and virtually. We have Zoom running here. And we're so excited as well about everything we've been able to accomplish this year as students, staff, faculty, the community, everyone coming together. And as evidenced by all of these great posters around the back that you've seen. Let's give a round of applause for all the students that come.
We'd also like to give a special thanks to the Eccles Fund, without which most of this would not have been able to happen. We'd also like to thank our various stakeholders and community members for joining us today. Your support is essential to the success of the symposium and of the Student-Led Clinic initiative. We'd also like to acknowledge that we're on the ancestral lands of the Ute, Goshute, and Shoshone people today. We're pleased to start this session with an opening remark from Dr. Michael Good, CEO of University of Utah Health and Senior Vice President for Health Sciences.
Thank you. It's just so wonderful to be here, to see you all. So much good stuff happening. It's happening all year long. But we get to really celebrate it here. You know, with community in mind, student-led clinics are one of the key components of the mission-driven MD program, the new curriculum that's now being implemented in our medical school. And I've been in either an assistant, associate, or a dean of a medical school position for coming up on 20 years. And I've been involved in two really substantial medical school curriculum revisions prior to this one. This one knocks my socks off. I am so impressed with what you all are doing. Of course, I really need to do a shout out for Dr. Sarah Lamb and her leadership team. I've watched this develop over the last few years, and to see it now not just being implemented, but to see early signs of just phenomenal success. I can't tell you how excited that makes me. For our medical students to have such meaningful early clinical experiences is absolutely what needs to be done. To have service learning achieved through partnerships being such an important part of this journey. You know, I overuse that line, you know, it takes a village. Something like this really does take a village. I also want to give a shout out. I saw Dr. Brian Shiazawa here. Brian, can you stand up for just a second? Brian is the Associate Vice President for Health Policy, and one of our clinics is the Rose Park Population Health. Brian was the person behind the scenes. He always says, Mike, you did this, you did that. No, I don't do anything. Brian connected all the dots. It's also been mentioned, the Eccles family, the endowment gift that was given to the medical school, Spencer Fox Eccles School of Medicine. The payments were supposed to be come in over 8 years. I think the Eccles have already made 5 payments in 1 year, something like that. They've kind of prepaid the endowment. What does that mean? That means it's generating, as the term says, spendable income. And we've invested that income in our student-led clinics. So the Eccles are a big part of this journey. And I want to welcome back Dr. Robert Miller. Dr. Miller, it's great to see you again. We were comparing notes. It's been a year already since you were last year, but great to see you back with one or more of your students. Thank you for being a partner on this journey as well. So hats off to all of you on the projects, mostly the projects, but the posters, the breadth of what is already happening in these student-led clinics, just really months into their existence. I'm just very impressed, and I can't wait to learn more. So JB, back to you.
This keynote plenary sessions dedicated to topics that we felt were salient across all of the clinics. There's of course differences between each, uniqueness that we cherish. And this session pulls a lot of that together. First, we're going to have MD PhD student Krishma Shah to talk about the incorporation of community healthcare workers and the vital aspect and vital role they play in our clinics. After that, we'll have Tessa Jolly on the empirical research that's being done both here at the university and elsewhere on student-led clinics and how we can better incorporate what we're doing into that body of literature. And third, we're going to have the MBA capstone team give recommendations that apply to all of the clinics on how we might operate more effectively. So we'll turn the time over to Krishna.
All right, thank you. And thank you for inviting me here to speak about my project today. I'm really excited to be here. My project that I'm going to talk to you about is the project that we started. It's partnering with community health workers to engage in community-based participatory research. This is not a project I did by myself. I had other students helping me, Jasmine, Sonia, and Ciale. I don't see any of them here, but a huge thanks to them and all the work they put into this project. I want to start off by saying that this project was actually funded by the Utah AHEC Mini Grant Program. And for all the students that are here, all the med students, if you're interested in like getting grant funding or small grant fund to like further any of your projects or initiatives, this is a really great way to do it. The applications to become an AHEC scholar closed February 28th. So this is something just to think about. It was a really amazing experience actually having money to run a project like this. So our project really wanted to focus on how can we go into underserved communities, how can we hear their stories and experiences and what they're going through and learn from them in a way that we can then bring back and use that insight to help better serve them. And so we use this qualitative research lens to connect with and learn from our underserved communities. And first, we wanted to characterize the experiences of underserved communities within the local healthcare system. And secondly, we wanted to actually assess how different underserved communities had different unique experiences and different unique needs. So what we did is we partnered with community health workers from 6 underserved communities in Utah. And I want to give a huge thank you to all the CHWs that worked with us on this project across all these different communities. The CHWs here with the red circles around them are actually community health workers that are engaged with current UVU med students right now. So it's just really amazing that we have the opportunity to work with these community health workers and learn from them and serve our communities with them. So we partnered with them. And we kind of designed these focus group prompts. And what we did is we went to the community health workers and we asked which of these questions are most relevant to your communities? How can we design a focus group that is very relevant to your community so we can learn the most from your community members? These are some sample questions, but there were 6 main areas. We asked about health and wellness, healthcare ideals, individual needs, interactions with healthcare, navigating the healthcare system, and integrating culture into healthcare. And I want to say one of the most amazing things is that the CHWs we work with actually really helped us tailor each of the focus groups to their individual communities. And I think it's one of the reasons why we got such vulnerable, honest answers from the community members. And so that was a huge part in what we did. Then we conducted 1 to 2 CHW facilitated focus groups in each of these communities, transcribed, translated, and then conducted qualitative analysis and generated themes. So these are just some numbers for the number of focus groups we conducted, total number of participants in each of these communities. And 8 themes emerged from our qualitative analysis. The most prevalent theme was barriers to accessing care, which are factors that affect how difficult it is for community members to participate in the healthcare system. And this quote, "You can't have a healthy community when people can't even get to the doctor's office." The second theme that emerged was this theme of personal or systemic trauma and just the negative emotions that arise when interacting with the healthcare system. And what was really interesting is that this theme came up in both individual, like personal and historical context. One of the quotes, I will put something off until it's just really bad for the fact that I hate to be judged." I think this is a sentiment that a lot of underserved populations resonate with. The third major theme that emerged was this idea of humanistic healthcare, attitudes and behaviors demonstrating interest in and respect for patients' psychological, social, and spiritual concerns and values. And this quote, "Let's stop calling a healthcare patient a customer. We're not customers. We are not numbers. I'm not a statistic. I'm a human being. I'm a healthcare patient. And how can we empower all of our healthcare patients to feel this way?" The fourth thing that emerged was this idea of building relationships. So efforts within the medical system to build meaningful and lasting relationships with both individuals that come into the clinic and the communities that they serve. And this quote of their doctor does a great job, always gives me information about new treatments that we decide to do. We do it as a team, so I have trust. I trust him. The next theme was centered around cultural competency, this ability of providers and organizations to effectively deliver healthcare services that meet patients' social, cultural, and linguistic needs. I really like this quote of how nice would it be if all of our customs, our way of being, were well understood. That would be ideal for each one of us because our health is at stake. And I really like, if you think about what that means, like how important it is for you to be seen when you go access healthcare. The next theme of dimensions of health refers to the diverse ways that people, communities, and cultures conceptualize health and well-being. Health refers to the physical, mental, and emotional well-being that keeps you balanced, that keeps you in a full state of personal certainty to be able to conduct yourself in the best possible way. The seventh theme, navigating the healthcare system. This just applies to how people approach entering, navigating, getting their needs met within the healthcare system. And this quote of, that is also where my fear comes in from seeking medical care. I think I'm going to mess up somewhere like that because I have so many times because there's so many fine prints. I still feel this way as a medical student, and I'm sure a lot of patients feel this way too. And something to keep in mind when interacting with them. And the last theme of advocacy, ensuring access to care, navigating system, mobilizing resources, addressing health inequities, influencing health policy, and creating systemic change. And then focus group participants would talk about, like, I do find sometimes that it's hard to advocate for myself. Again, it just comes down to that intimidation process. So how can we empower patients to advocate for themselves as well? So the 8 themes that emerged were really great, but I think the cool thing that came out of this project is the fact that each unique community, theme prevalence varied among them. Different themes were more or less important to different communities. So, for example, in the African American community, this theme of personal or systemic trauma was really prevalent, and a lot of it had to do with historical context, historical trauma affecting the way things are today. So many things happened previously. They didn't start today, healthcare, and especially healthcare for my community. And they, the supposed helpers, were sabotaging us at one time. And not only me, but others as well, all the races as well. So there's this big question mark about what are you really doing with me? What are you really giving me to take? So there's a lot of questionable past activities that blend in today's decisions, if you will. And then this other quote. So my problem is when my doctor refers me to a specialist, I'm always the person who thinks, is he going to accept me as a Black person and do right by me? Are they going to feed me? Are they going to be back there doing something to my meal? You can never tell. And that's how I feel seeking medical attention. And I think that's just a very heavy feeling to sit with, that patients come into the clinic with these thoughts and these feelings. In the Native American community, this theme of dimensions of health was the most prevalent theme that came up. And this idea that health is so much more than just being physically healthy. So I believe that health would involve or include not only being physically healthy, but being mentally healthy and spiritually healthy. And then, another thing I think many of us do, our native ways, our prayers. Always pray for yourself, pray for your family, and pray for community, pray for home. It doesn't hurt to do that. There's a lot of ways we can support ourselves and each other and anybody that wants it. Pretty low charge. I think for this community especially, what can we do to help empower all these ways that they attend to their health and the health of them, their family, and their community? In the Pacific Islander community, this theme of humanistic healthcare was really prevalent. For me, like in the past when I've gone to the doctors, I do not know why it didn't feel like a safe space. The place you go to improve your health and empower your life doesn't feel like a safe space. That's a hard thing to sit with. Like my ideal visit would just be to know that I'm getting taken care of and that my concerns about my health are being listened to and stuff like that. I know especially with like therapist-wise, they don't really understand my experiences being a Pacific Islander and stuff like that. So it's really important to think, how can we see each of our patients as humans and validate what they are going through, even if maybe we don't have the same experiences as them. In the Hispanic Latino community, barriers to accessing care was the most prevalent theme. The system is very confusing, yes, really, and sometimes not in your language, so it makes it more complicated. And then because sometimes the translators or the children translate, or the translator sometimes, you also get the wrong diagnosis, but they do not know the terminology. Some of the older people who are translators are people who can learn something and do not handle a simple terminology to explain to the doctor or to the patient. So how can we focus on addressing some of these barriers? And I saw a poster back there about translation services, which was awesome. And then the rural Utah community, the most prevalent theme was barriers to accessing care. And a lot of the community members talked about telehealth and how it's kind of changed the way that the rural community accesses care. But the quote that I thought was really beautiful was this building relationships quote. And remember Dr. Jesse, he used to do Saturday walks with Jesse or whatever. And I thought that was kind of cool. Yeah, just so we could get familiar with his patients or they feel comfortable around him. Like he would just go for a walk and whoever wanted to go could go. He's such a cool person. He's perfect for rural care. I feel like that's such a heartwarming example about physicians going and building community with the patients they serve and making sure that their community feels comfortable with them. And so those are the results from this project that we did. And then thinking forward for the student-led clinic initiative, I just thought I'd take a moment because I know we've been running these student-led clinics for a bit. If any of the medical directors of the student-led clinics wanted to share any insight, have any of these themes kind of come up in your clinic and in what ways? What have you seen, experienced, noticed? If anyone feels like sharing, no pressure. Yeah.
I'm happy to speak up. So I'm one of the co-medical directors at Midvale Community Building Community Clinic. And I mean, all of these themes are common among the patients that we see there. The one that jumped out to me probably predominantly, or at least first come to mind, was about barriers to accessing care. And the referral system from Midvale is fairly complex because we're dependent on donated care and donated imaging, donated labs. And so there are like 4 or 5 different health systems that are interfacing with Midvale in order to get our patients access to subspecialties and imaging and labs. And that can be really difficult for our patients to navigate. And it requires a lot of work by the clinic to make it happen. And then also just a lot of work by the patient to then go do it. And then a whole bunch more work to get it all to the same place.
Yeah.
And to achieve good care. And so that becomes a major barrier for our patients.
Absolutely. And that is what a lot of the community members talked about too, is like, I go to the doctor and then I'm told to go to these 3 more places. How do I find childcare for these 3 more things I have to go do now? And how do I keep up? Honestly. Yeah. Thank you for sharing. Does anyone else want to share? Okay. All right, well, that's all I have, but for the discussion questions that we're going to be having later, there are a couple questions that I'll just throw out there now. If you have any thoughts or want to chat about it later, I would be more than happy to. The first question is, what are some barriers that prevent students and providers from reaching out to community health workers for support? Like, what stops students, especially, I think, from reaching out to community health workers and getting that insight in the moments that they need it? How can we facilitate students building longitudinal relationships with community health workers from various communities? Because sometimes it can feel like you reach out to a community health worker to solve an immediate problem, but how can we work on building that longitudinal relationship so that community health workers are more part of the system and students are right there building that relationship with the community health worker like they would with any other provider? What would a tool look like that allows students in clinic to engage with community health workers from the same communities as their patients? I think that also brings up the question of, is like a handful of community health workers that serve a diverse population, is that enough? Like, or do we need more insight from more community health workers? And then question 4, how do we support providers and student-led clinics to be role models for cultural competency and humility? I think that's something we're all learning how to be better at together. And how can we just all support each other in that process? And then how can we integrate solutions for these themes into the patient care process, specifically like including it into the HPI of like how have you worked with a community health worker before? Is that someone we can contact beforehand to get an idea, get more context for how your health fits into your life at this moment and stuff like that. So we'll definitely be discussing this later at table 7 if anyone is interested. Thank you for your time.
We have time for this one.
Absolutely. If anyone is.
So if there's any questions, we have time for 1 or 2 questions. Thank you so much, Krishna, for this.
Thank you.
Appreciate it.
Those of us in this online group are blocked from asking questions at this time, I suppose.
Hi, my name is Tessa. I'm a second year medical student here at the U. I am also one of the student directors for Rose Park Clinic. I'm the director of student and patient services. And I'm really excited to share a perspective on research into student-led clinics with you today. So first, let's dive a little bit into the background. So in 1967, let me double check the name. I think it's the Student Health Action Coalition, which is affiliated with UNC, was opened as the nation's first student-led clinic. Now there's over 200 student-led clinics, but notably this number was obtained from a paper in 2014, where they did a survey. And so there's serious need for updating that number. The Society of Student-Run Free Clinics suggests that the number may be closer to 400 now. So a really, really broad range of growth since 2014. 75% of medical schools have student-led clinics, and 72% of medical students have participated in student-led clinics. This is a number from the AAMC graduation questionnaire in 2021. And then here's just a great picture of some of our Rose Park students and our medical director here at Rose Park. So as I said, 75% of medical schools are affiliated with at least one student-led clinic. We are lucky enough to be affiliated with 5. So I just wanted to capture a little bit of how our 5 clinics capture a good portion of the Salt Lake City metropolitan area and outside cities. We have a really, really great team of clinics here. So diving into the strengths and weaknesses of student-led clinics, and Smith et al. In their paper found that some of the strengths of student-led clinics were serving the underserved in student education, and some of the weaknesses were faculty staffing and funding. Another weakness that has been suggested as well is continuity of leadership in student-led clinics. So now let's think about how we can create opportunities and ask the right questions by looking into the research that's been done on student-led clinics. This is obviously a really, really broad field of literature. So I've done my best to kind of synthesize this today. I found that this paper by Rupert et al. Captured this really well. They looked at the literature pertaining to student-led clinics and their impact, and they've tried to make an argument that more research should be put towards student-led clinics in undergraduate medical education. They examined 20 years of literature into this topic, and they looked at the impact of student-led clinics with regards to 3 roles, as advocacy organizations, as components of medical education, and as medical care providers. And I found that that kind of framework of looking at the research pertaining to student-led clinics is a really, really good way of breaking it down. And so we're going to look at it through advocacy, care, and education today. So diving into advocacy first, here are just a few of the topics that have been looked into in terms of research pertaining to advocacy in student-led clinics. I would also say too that just walking around our posters today, we actually kind of have a really good sample of research that's been done in student-led clinics. There's, for example, a specialty care for the underserved. We have an ophthalmology research paper presentation that was done today. Access and cost barriers by insurance status. We didn't necessarily have one that I see there, but we did have a good presentation by Midvale where they were talking about prescription drugs for patients, which is excellent. Student-led clinics, that people have also looked at specialty selection, advocacy, interprofessional health education. So there's a lot of topics that will hopefully get you thinking about the questions that you might want to ask if you're looking into doing more research and contributing to the field of research in student-led clinics. So now just looking at a selected paper from the field of advocacy, I thought this paper by Suresh et al. Was kind of a good example of research into advocacy because it talked about the attitudes that students develop after working with medically underserved communities. I think that this is a really important thing to think about because student perception of the importance of working in medically underserved communities is really crucial to advocacy in the future. So this was done by the Giesel School of Medicine at Dartmouth. They had 15 volunteer MS1 participants and they had an 8-month curriculum with classroom didactics and community partnerships. Part of it was virtual, part of it was in person. And so that's kind of an interesting aspect that we could talk more about if anybody's interested. They administered a medical student attitudes toward the underserved questionnaire at the beginning and the end of the program. And they found sustained positive attitudes towards underserved populations. I will note that their findings and the difference between their control group and between the beginning and the end of the curriculum were not statistically significant. So I found that that was a really good point to make about an opportunity for more research here. But the kind of preliminary research that has been done in this field is really promising. And I will say that advocacy specifically is a field within this kind of broader scope of student-led clinic research that's definitely needing a lot more looking into, which it was definitely well demonstrated by Krishna's amazing presentation. So diving into care, here's a small selection of the topics that have been described in the literature. So strategies for clinic expansion, again, drug costs, which we've had here, HIV screening. And I thought another good thing that we demonstrated here was this specialty care. I think I already mentioned ophthalmology. I don't think we had any others, but in the research, there have been gynecological care done at student-led clinics, prenatal care, preventive care quality. People looked at diabetic and cardiovascular care at the student-led clinic. And then just looking over general patient satisfaction outcomes is definitely a big thing that shows up in a lot of the papers. So yeah, so just again, thinking about all these topics that other people have been looking at and what questions we might be able to ask. Here's a selected paper within the field of care. This one is actually from our friends at Shade Tree Clinic, who we were lucky enough to have with us today. And I thought this was a really good paper because it provides oh wait, hold on, I completely lost my spot. Here we go. So I thought this was a really good paper because they kind of got to look at the impact that medical students can make in patient outcomes. And diving into the paper a little bit, they did a retrospective review of 45 medical records of their type 2 diabetes patients, and they looked at the change in hemoglobin A1C values relative to the number of clinical touch points. These are interactions with medical students. And they found that the A1C values improved significantly, statistically significantly, from 9.6 to 7.9. So a really, really great improvement there. They also found a trend that, while not statistically evident, suggested increased number of touch points improves hemoglobin A1C values. The reason this stuck out to me is that I think it's a really good example of how student-led clinics and care by medical students in student-led clinics can be just as good, if not better, than the care that you receive elsewhere, especially if we do it right, and especially if we ask the right research questions to try to improve the care that we offer. Diving into a few education topics. So these topics here, that's kind of broad again. Education is, I would say, within the literature, perhaps the most difficult to capture. The learning outcomes, for example, but also one of the most popular ones to look at. So people have looked at peer mentoring was definitely a big one. Musculoskeletal education was another great example of looking at a specialty, but specifically with regards to education within that specialty at a student-led clinic. How it influences student attitudes and readiness going into clinical rotation. That's definitely a big one for us, considering student-led clinics are, sorry, I think I took the mic away from my mouth for a second, but that student-led clinics are directly integrated into our curriculum. So making sure that our students are prepared for clinical rotation is pretty essential to the U at least, and hopefully to other medical schools as we move forward in this field. So a selected paper from the education side of things. I picked this review I think it provides a good overview of the current evidence for improved learning outcomes in student-led clinics, as well as a basis for the comparison of study designs and recommendations for improved learning outcome evaluation. That was a really big part of it. So they did a broad literature review. They used a mixed methods appraisal tool to assess the study quality. And notably, their main kind of findings within all of these papers, the clinical skills was the most common learning outcome reported, followed by interprofessional skills and empathy and compassion for patients, as well as more leadership opportunities for students and better leadership development. They did note that within these studies, there was really broad need for improvement in study design. They identified that with the mixed methods appraisal tool. As I said, education and learning outcomes are really difficult to capture, and that's something that I really love to talk about in our discussion today. Table 15, since Krishna shouted out hers. But anyway, so yeah, these study designs, they made a few recommendations in this paper. They said that data collection needs to be a little bit more careful. The design of the study could be a little bit more strategic and better capture the outcomes that you're wanting to look at. They could provide better details if you're hoping to write a paper about a student-led clinic. You could provide better details on the operations of your specific student-led clinic so that readers of the papers can figure out if that specific paper is applicable to them and to their clinic. You can also provide details about the intervention, specifically about interventions that are more longitudinal, because a lot of the time with these papers, it's a very short period of time. You don't really see if the learning outcome is actually one that you're going to see long term. And so in short, I really appreciated this paper because it talked about all of these findings that we really want to capture. Those learning outcomes, interprofessional skills, empathy and compassion, those are the impacts that we're really trying to make with our student-led clinics and with our curriculum. And I think it really captured the whole scope of the curriculum well, even kind of this whole scope of this breakdown that I had with advocacy, care, and education. That's all kind of representative within this paper and within its findings. So to summarize, as we've all become acutely aware through this curriculum journey, student-led clinics come with strengths and challenges, but they also offer a lot of unique opportunities in the realm of community advocacy, patient care, education. I'm really driving that point home. My hope is that this brief perspective on the research will get us thinking about questions for the discussion, table 15, and not only to improve our own clinics and our curriculum, but also to contribute to the broader literature as it applies to student-led clinics, so that we can enter this in a really research-based way and become a player in this field. These are the references if anybody was interested. There's a lot of them. You may have to look at it after the fact. But thank you so much, and I hope you guys will be at the discussion, helping think of some good ideas.
So we have time for a few questions. The first is from the Zoom chat. Is there data on how SRHCs influence specialty choice, more or less primary care?
So there are a few papers on that. I didn't look at their findings specifically because that's very broad literature review. But I think there might be a paper in my references. I would look at the literature review from Rupert et al. They will capture that data there. They'll have a reference. Yeah.
Any other questions before we? Let's give another round of applause to Tess. So next we'll have the MBA capstone group giving a few recommendations, and I failed to introduce them, and I apologize for that, but we'll have Justin Bowman, Patrick DePasquale, and Walker Krebs and myself to give a little bit of an overview of the project we did and how it might impact how we think about the way we do things in our clinics. Yes.
Hey, so first of all, a lot of us aren't here right now, but most of us during this project were all MBA students, and we had to do our capstone project, which was basically we picked the projects for that we could really apply what we learned during our time in our MBA, and the Rose Park Clinic was an amazing opportunity for us, and we truly did learn a lot, and it was great to work with the people that worked with the Rose Park Clinic. So first of all, our mission was to, work with a innovative and sustainable model of care and try to find out ways to improve the clinic and really kind of bring apart that mission in providing an exceptional educational experience for students and making sure that there's quality, equitable, and affordable primary care for the Salt Lake City community. The tasks that we kind of wanted to focus on was kind of threefold. We wanted to do a marketing portion, an operational portion, and a finance portion, in which we kind of dived into the current insights of how's the Rose Park Clinic marketing itself. Like, is it getting patients? Is it, I don't know, what does it look like to the outside world? We wanted to then dive into key focus areas and then make our recommendation.
So for marketing, like I said on the previous slide, we really just wanted to grow the patient panel. So really get the word out about the Rose Park Clinic. So kind of anecdotally, on our first meeting that we had as an MBA team in the Rose Park Clinic, we had a little bit of a hard time finding the clinic. We typed it into our phones. Rose Park Clinic, turns out there are 2 Rose Park clinics, so half the team went to the wrong one. And once we got to the right one, we weren't sure exactly where to go. There were no signs on the outside of the building, no signs pointing us upstairs in the inside of the building. So we took that into account when we looked at our marketing recommendations, what we wanted to do. So we looked at kind of 2 different areas. One is the online presence, and one is sort of physical pamphlets and spreading the word throughout the community. So for an online presence, social media is a great way to spread the word. So creating an Instagram page, X, formerly known as Twitter, Facebook, LinkedIn, any social media outlet, and then search engine optimization. And so that goes back to that, searching on Google's Maps for the Rose Park Clinic. With search engine optimization, that'll boost up the U of U Health Rose Park Clinic so that it's the first or at least near the top of the results. And then Google Analytics is a way to monitor the effectiveness of any social media campaigns, search engine optimization to figure out how people are finding out about the U of U Health Rose Park Clinic. So we looked at adding signage as well, and I believe since then, I think our first meeting was 6 or 7 months ago. Since then, signage has been added to the outside of the building, so it's a lot easier to find now. We're not getting lost quite as easily. And we looked at printing marketing pamphlets. So a lot of the population still has little or no access to the internet. So pamphlets are a key way to spread that. So building relationships also is another huge way to spread the word about the Rose Park Clinic. So looked at building relationships with places like libraries, transportation, so that could even just be bus stops, schools, shelters, so the homeless population. Refugee centers is another huge avenue, another huge place the Rose Park Clinic can be reaching out to. So there's actually a refugee center right around the corner from the Rose Park Clinic. And as of 2017, there were 60,000 refugees in Utah. And that number has only been growing since. Community centers is another place we looked at just to spread pamphlets, spread awareness. A lot of families go to community centers, and there are a lot of community centers in the area that could benefit greatly from having affordable health care and access to a place like the Rose Park Clinic.
So as MBA students, we during our educational experience, we were taught to maximize profits, maximize sales and whatever. Really, so when kind of coming into this project, we that's kind of the mentality we had. But quickly we learned that rather than maximizing, we wanted to optimize, especially for the learning experience for the medical students and the clinic overall. So we ended up focusing on 3 portions within the operations. We wanted to look at how the students are feeling with their educational experience with the Rose Park Clinic. We want to look at patient outcomes, And then we wanted to dive into clinic flow. And we thought that by really focusing on these three aspects, we can optimize the clinic overall.
Perfect. So our first step in kind of our analysis of operations was to create a diagram that mapped out all the processes that happened at the clinic and who did those processes, how long it took. And as you can see, the medical student who's in the student provider role does a lot. So a lot of the processes that took the most time were with that student. And we tried to focus on making sure that we didn't reduce the students' learning opportunities. So the part that takes the longest is the history and physical. And we kind of deemed that that was protected time because we didn't want to cut back on the students' time with patients. The other two areas, the assessment and plan, are a great learning opportunity for students to kind of put their clinical knowledge to the test. And that takes up some time. And then the most fun part of healthcare documentation also took up a significant amount of time. So those are the three areas that we identified as potential spots for us to implement some places to improve the clinic flow. And we also got some feedback from a student survey, which Patrick's going to talk about. And we tried to tailor our recommendations to meet those three areas as well.
Back. Upon our survey, so we kind of wanted to see like what do the students feel about the clinic overall. And the first question we asked was, what is your current learning experience and how would you rate it? And they rated it an average of 2.5 out of 5, which is that's pretty good. It's a brand new clinic and like it's been doing exceptionally well. But there are definitely areas that we found that the students thought needed improvement. A few of those areas where students expressed the need for increased training in EPIC and clinical roles. A lot of people got in there and they spent a lot of their time just like not knowing how to even navigate EPIC and what to do. We saw that students expressed a desire to see more patients. The clinic flow was very low. So some students are getting experience in other clinics and other students aren't. And we think that by increasing marketing and other stuff like that, you can get there. We also saw a feeling of a need for increased mentorship and clearly defined expectations. A lot of students thought they were going to get in here and learn to diagnose and really get like a full dive in and their first years, but they thought they were going to do a lot more than they actually did. So kind of laying out like a list of expectations of what you're going to actually do during the clinic is we thought would be very important. From there, the recommendations we kind of wanted to make were we thought it'd be nice to have a mock clinic during scope. We think that, again, defining clear learning expectations for what your students are going to learn during your time there so they're not underwhelmed or overwhelmed. And then having assigned roles. Some students were go-getters and wanted, when given an opportunity of like, who wants to work with these patients? You had some kids that were always like, yes, me, I want to work with, do this. And other kids that were maybe more reserved, didn't get that. And they felt like they weren't getting as much experience as the other students. We think that working with patient scheduling would be super important. And also, like one of the big recommendations we found were there's a desire for maybe a third or fourth year presence within the clinic. Maybe the provider doesn't really have a whole lot of time to work individually with certain students, and maybe having a mentor there to aid in maybe figuring out how to work out EPIC and stuff like that. But we think that would be good, and we've heard that they're doing that by making a dedicated elective where those third or fourth years can work with the clinic and get those hours.
So the last part of our project was to focus on the continuation of the financial viability of the clinic, what that will look like. We really live by funding from the medical school and from other organizations, from governments, and we're so grateful for that. And we have to think about, what is the best What is our best use of our time and resources that we've been given? How do we stretch those the farthest we possibly can? How do we be the best stewards we can over what we've been given? And ultimately try our best to be sustainable on our own. And can we make that happen? And asking those questions is, we believe, essential for every clinic. That every clinic needs to be thinking about that, needs to be thinking about how can we continue to serve these communities in the event that becomes a lot harder to, in the event that the legislation changes and that we get less money. How do we, everyone should be thinking about how can we do that for our patients. And one of the ways that we've thought about that, and this is a bit unique, talking about fee-for-service and value-based care, because this is typically talked about in the context of patients who have insurance, because these are contracts with insurance companies. And my personal opinion, what we've talked about as a team, is that when we talk about value, we go forward one more. There we go with the full slide. When we talk about value, it's the transition to doing things, being reimbursed for things that have an impact on a longer time horizon. You stretch out your time horizon a little bit, and you're reimbursed for taking care of people when they don't need really expensive care down the road. You're reimbursed better for that upfront in a lot of ways. It makes sense for a lot of systems to transition that way and clinics to transition that way. And some of you may be thinking, you know what, none of my patients are insured. This doesn't apply to me. I would say it does, to really think about the needs of the patients. If you're really doing your best to serve them, you would think about, how do I prevent them from incurring massive expenses down the road? Whether you're doing that for an insurance company or just because you care about your patients, it's the same thing. And the things you'll implement, the things you'll do to improve the systems that insurers like to see will actually be better for your patients too. And so from even a philosophical level, we thought, this is what we need to do to actually align the incentives to get patients better care from the beginning. So we can talk till we're blue in the face about how we build a patient panel for value-based care. Tables 4 and maybe 5 too, if you want to meander over there. We'll be talking a lot about that. But we just wanted to give a couple of insights that we've derived from thinking about this problem, and then more specifically to what the clinics might do in more of a practical way. There's been 6 proposed general steps to moving towards a value-driven or value-based system or a value-based clinic. And that's first to align provider panels with at-risk patients, identifying the patients that need the most help, who maybe we don't right now know about, or we do, but they're not being seen enough. They're not being seeing the right people. They don't have enough touch points to actually get the help that they need. To restructure the teams and workflows around those patients, not expecting patients to come to us. We go find them. We engage in follow-up calls. We engage in things that perhaps we're not reimbursed for, but that we think are important for giving the best care to patients. Third, providers and teams have to work together to know about this, to know about how to think about this in a way that is a much longer time horizon on managing this person's A1C right now is incredibly important. But we also need to talk about what they're doing when they're not here, when they're not getting their A1C drawn, that affects that, and knowing that. We already do that, but systematizing that is essential for this. Novel technologies are important for this as well. If patients need a fridge to store their insulin, you need to get them a fridge to store their insulin. And paying for that makes sense when we're operating in a value-based model. Real-time insights are also incredibly important because the more data we have, the better decisions we can make about these patients. And that's obviously essential as well. And then aligning incentives is the crux of the whole thing, making sure that patients that need the most care at any given time are actually the ones being seen in the clinic, and we prioritize that. And the incentives driving that are actually aligned with that patient panel. You can just click through all of them. Thank you. So the things that we thought would be helpful in doing this, because those are fairly nebulous concepts of like, okay, we love this idea of like do things better, make a good system. But the things that we can actually do as clinics, as student-led clinics that we can take ownership of is doing data collection and reporting systematically and really, really well. Getting all of the data we might need to identify these patients, making sure we know those numbers, know what our payer mix looks like, know all of those things, and dial down those metrics that we feel confident they're correct and that we can make data-driven decisions because of them. having a risk profile and impact study of our patient panel, knowing based on data from the university that we have access to and other databases, what are the factors influencing the likelihood of needed care in the future, and what disease pathologies can we stop on the front end, and using data to actually make those decisions. Targeted marketing is also very, very important, talking about actually, not only do we identify those patients, but we actually convince them that they should come to us. Of course, community healthcare workers are essential in that mission of helping patients who need to be in the clinic get to our clinic so we can see them, and we can play a role in that as well. Transitions of care are obviously very important. When a patient discharged from the hospital and they don't have a primary care doctor, there should be immediate follow-up, if not from another primary care clinic, to one of our student-led clinics. If they don't have somewhere else to go, it's often a great avenue for that, and they're often left without a lot of direction at that point in their care. Once this has been, once these four things have done, you can begin to negotiate with the different, both the payers that you interact with and also government entities who insure many of these patients and who have incentives to give a lot of money to clinics and to health systems that are able to take care of massive problems before they become those massive problems. And that's why we care so much about preventative and primary care. And that's why we're all here to actually do that for these patients. 6, we mentioned future capstone teams because we think it's essential to be thinking about these things. Medical students are stretched very, very thin, and incorporating a collaborative effort with the business school and other schools as well, bringing people together to think about these issues, I think will be incredibly fruitful as we think about how to do this in the very context of each of our clinics. Lastly, one of the concerns that we talk about and think about is a revenue drop as you transition to a value-based model. And this is a little bit more in the weeds, but something we wanted to bring up because it's a unique aspect of student-led clinics in general, that we have a workforce that is very, very effective and that is great at seeing patients that we don't happen to pay. I mean, we could change that, but medical students right now are not paid. And as we enter this period, we're uniquely, a lot of the models and projections that are run in these simulations are based on actually paying staff, and we don't do that in the same way a normal clinic would. And you have to consider that. You have to consider what that looks like and how that impacts this period. Also, there's pre-funding contracts that we've talked about. You can mitigate losses in transitioning to a value-based care system by making contracts specific with insurers to mitigate that risk of that drop. And then also for Rose Park specifically, the number is 34% of Medicare and commercially insured patients. So when you do this with Medicaid patients, it's much more reasonable to make this happen. And then, of course, again, our unique advantage is the students. We mentioned the touch points that are so important, and the impact that students do make is incredible in these clinics. And it goes without saying that it's mutually beneficial. But there really is a big difference being made in these patients' lives. And I think it's important to recognize that as well.
You have time for a couple of questions if anybody has some for this group.
Do you have any data on how the marketing efforts, SEO, et cetera, that your team did, what effects those had on the patient panel, both in terms of size as well as any demographic changes that have occurred?
The question for those on Zoom was about data on the impact that the marketing has had on the patient panel at Rose Park.
So we actually gave these recommendations just about a month ago, a little over that. So we don't actually have any current up-to-date real-time data for the effectiveness of that.
Do you have one more question?
Just on the SEO, are you doing just English as the primary language?
Question for those on Zoom is whether or not English is the only language for the SEO.
The SEO, I mean, whatever the target market is, right? So I think English and Spanish are the two primary focuses here. And these are things that, again, they're recommendations that we've made, and I'm not actually really up to date on the current status of if those recommendations have been fully implemented. So that might be a better question for some of the student-led directors that they'll hopefully be implementing that.
Thank you guys for sharing your work, and it's been really cool to see it play out in real time at Rose Park. So before we transition into dinner, I'd first like to thank our students again for presenting today. You guys have done really amazing work. We are also lucky enough to be joined today by President Randall, President of the University of Utah. I'd like to turn the time over to him to make a few remarks.
Well, first off, thanks for letting me come and take a few minutes before dinner. I'm sure you're starving. You've been sitting and listening and learning. This student-led clinic concept is absolutely spectacular. I've been following it conceptually for a number of years now. Congratulations to all of those that are participating and have designed it. It's just absolutely remarkable. I am a massive believer in empowering students to kind of create their own educational experience. I think it drives passion. You find your passion and suddenly you learn a lot differently. I was just looking at the diabetes education in student-led clinics, and it reminded me of a couple things. If I might make a couple comments. Anyway, I love the idea of trying to use incentives and to see if they work. I've done some incentive work myself in my economics career. I've actually got a good friend that I went through my PhD program with, who's an MD and runs a health incentives clinic out of the University of Pennsylvania. And one of the funny things he found is you can actually pay kids to eat vegetables, and it has a persistent effect a year later. And in fact, so I don't know if it would work there, but one of the funny things is I had him come in. Many of you don't know, during the pandemic, I was put on a team to try to figure out how to help with some of the problems. And we made this observation that the only people in high schools that weren't getting COVID were football players. And the reason was either they were cheating the system, but we figured out they weren't. But they were actually self-protecting because they all wanted to play. They had to test the day before, right? So here you had this massive incentive system and nobody was getting COVID. So I put together this, they called it a scheme. I thought it was genius. So I said, why don't we pay high school students not to get COVID? So I just said, we're going to randomly test. Anybody that gets randomly tested and doesn't have it gets $100 a week. And they didn't go for it. They don't. Anyway, but I think it's that kind of creativity, right? That when you bring a whole bunch of people into the room, you suddenly get just a very different view of how we can solve the world's healthcare problems. And that's what excites me most. And I'm going to take a look around the room, and I won't have any more comments. And you can, by the way, I don't think those I just gave were particularly good, but anyway, it was fun to spend a few minutes just thinking about what you're doing. Pay to avoid carbohydrates. Anyway, thank you for everyone and all your leadership. This is something that I actually do a little bit of funding out of my office because I believe in this, and I'm going to continue to do this. So keep going with the innovation, and thank you for all you're doing to make this university and healthcare excellent. Thank you.